Hello everyone, welcome to Renal Rehabilitation Laboratory. This is you, a physical therapist. This time, I'd like to talk about this question. Is there any determinants which predict difficulty in activities of daily living in ambulatory hemodialysis patients? As the importance of patient-reported outcomes are recognized, the research about these topics are increasing. So, let's learn about it. Today, I'd like to talk about this cross-sectional study, determinants of difficulty in activities of daily living in ambulatory patients undergoing hemodialysis. Evaluation of physical functioning in HD patients is recommended, as decreased physical functioning leads to a reduced QOL and higher risk of mortality in this population. Self-reported measures of physical functioning have the advantage of being simple and easy to use. In Japan, more than half of HD patients reportedly have the ability to perform ADL tasks without assistance. However, even HD patients who can perform ADL tasks independently show high rates of ADL difficulty. Kuttner reported that HD patients are more likely to have ADL difficulty compared to age-matched controls. ADL difficulty has been shown to be an early predictor of loss of independence and mortality in older community-dwelling people. However, few studies have examined factors associated with ADL difficulty in HD patients. This study aimed to identify factors associated with ADL difficulty in clinically stable ambulatory HD patients. From July 2007 to October 2016, clinically stable outpatients at the Sagami Circulatory Organ Clinic Hemodialysis Center were assessed for eligibility for inclusion in this cross-sectional study. Patients were excluded if they fulfilled the following criteria: hospitalization within 3 months prior to study enrollment, presence of uncontrolled cardiac arrhythmias, severe dysdialysis syndrome, peripheral artery disease with apparent intermittent claudication or critical limb ischemia, chronic heart failure, uncontrolled hypertension, need for walking assistance, and presence of any other condition that limited walking. They used a comorbidity index developed for dialysis patients to quantify comorbid illnesses, which comprise the following primary causes of kidney disease: atherosclerotic heart disease, congestive heart failure, cerebrovascular accident, transient ischemic attack, peripheral vascular disease, dysrhythmia, and other cardiac disease, chronic obstructive pulmonary disease, gastrointestinal bleeding, liver disease, cancer, and diabetes. A short 10-item version of the Center for Epidemiological Studies Depression Screening Index was used to assess depressive symptoms in the last 7 days. Each response item is rated on a scale ranging from 0 to 3. Total CSD score was ranged from 0 to 30. Higher scores indicated greater depressive symptoms, and the presence of depressive symptoms was defined as a score of 10 or over. Assessment of motor function included measurements of leg strength, standing balance, and walking ability. Leg strength was evaluated using a handheld dynamometer. Standing balance was evaluated by measuring one leg standing time. Walking ability was evaluated by measuring user walking speed along a 10-meter walking way. ADL dependency was assessed by the functional independence measure. The FIM comprises 30 motor items and 5 cognitive items, which are weighted on a 7-point scale. In this study, only 5 motor related to lower limb function were used. Transfer to bed, chair or wheelchair, transfer to toilet, transfer to tub or shower, walking or wheelchair propulsion, and stair climbing. A total score of 7 to 35 points, and lower scores indicated greater ADL dependency. ADL difficulty was assessed with a questionnaire developed for patients undergoing HD therapy to assess their perceived difficulty in performing ADL related to lower limb function, such as mobility. This questionnaire on perceived mobility difficulty for patients comprises 12 items divided into the following 3 categories, which were obtained by a factor analysis: basic ADL, ambulation, and walking up or down stairs. There are 3 items in the category of basic ADL: rising from a chair, rising from the floor, and sitting down on the floor. There are 5 items in the category of ambulation: walking 100 meters, walking 300 meters, walking 600 meters, walking 1 kilometer, and walking 20 meters quickly. And there are 4 items in the category of walking up and down stairs: walking up 1 flight of stairs, walking up 2 flight of stairs, walking down 1 flight of stairs, walking down 2 flight of stairs. Patients were asked to rate their perceived difficulty in performing these items on a scale of 1 to 5. Not possible, severe difficulty, moderate difficulty, mild difficulty, and ease. ADL difficulty scores was defined as the sum of all points and ranged from 12 to 60 points. Lower scores indicated greater ADL difficulty. The 12 items of the ADL difficulty questionnaire were classified into 3 difficulty levels: higher, middle, and lower. Then, patients with a perceived difficulty score 3 or lower for at least 1 item in each level were allocated into the difficulty group, and other patients who perceived difficulty score 4 or higher for all items were allocated into the non-difficulty group. From 2007 to 2016, clinically stable adult patients were assessed for eligibility for inclusion in this cross-sectional study. Patients were excluded if they fulfilled the following criteria: hospitalization within 3 months prior to study enrollment, presence of uncontrolled cardiac arrhythmias, severe dysdiuresis syndrome such as hypotension, nausea, and muscle spasm during hemodialysis, peripheral artery disease with apparent intermittent claudication or critical limb ischemia, chronic heart failure such as New York Heart Association classes 3 to 4, uncontrolled hypertension such as blood pressure arrest higher than 180 over 110, need for walking assistance, presence of any other conditions that limited walking such as dementia, low vision or blindness, paralysis due to stroke and leg amputation. 216 patients were included in this study. Mean age is 67.4 years and 130 patients are men. The most common underlying kidney disease was glomerulonephritis, followed by diabetic nephropathy. Mean ADL dependency and difficulty scores were 34.3 and 43.6 points, respectively. Figure A shows the distribution of ADL dependency scores. 42%, 130 persons scored 4 points. Figure B displays the distribution of ADL difficulty scores, showing wide variation. 4%, 9 persons scored 4 points. Patients found walking up 2 flights of stairs the most difficult of all 12 items, based on the percentages of patients with a perceived difficulty score 3 or lower, walking up 2 flights of stairs, walking 1 kilometer, walking 600 meters, and rising from the floor were classified as 88 items with higher level difficulty. Walking down 2 flights of stairs, walking 300 meters, walking up 1 flight of stairs, and sitting down on the floor were classified as ADL items with middle level difficulty. And walking 20 meters quickly, walking down 1 flight of stairs, walking 100 meters, and rising from a chair were classified as ADL items with lower level difficulty. The results of multivariate logistic regression analysis on ADL difficulty revealed that presence of depression and user walking speed were significantly associated with ADL difficulty at the higher level of difficulty in Model 2, and odds ratio of these factors are 4.24 and 0.94 respectively. At the middle level of difficulty, maximum leg strength and user walking speed were significantly associated with ADL difficulty in Model 2, and odds ratio of these factors were 0.97 and 0.96 respectively. At the low level of difficulty, user walking speed was significantly associated with ADL difficulty in Model 2, and odds ratio of this factor was 0.93. Cut-off values of user walking speed for predicting ADL difficulty at higher, middle, and lower levels were 83.7, 75.5 and 75.1 meter per minute respectively. Calculated in meter per second, these were 1.40, 1.26, 1.25 meter per second respectively. In this study, the cutoff value of user walking speed for predicting ADL difficulty at higher, middle, and lower levels were 83.7, 75.5, and 75.1 meter per minute respectively. These values were much higher compared to values reported previously, possibly because previous studies assessed ADL dependency in community populations. One study reported that user walking speeds of 1.25 meter per second and 1.07 meter per second predict the onset of basic ADL dependency in men and women, respectively, among a Japanese community population aged 65 to 74 years with no ADL dependency. In order to prevent ADL difficulty, higher physical functioning than that needed to prevent ADL dependency might be required. Therefore, the cutoff values obtained in this study might only be applicable to ambulatory HD outpatients. This study has some limitations worth noting. First, this study might lack general applicability due to the small sample size and the single-center study design, which included only Japanese HD patients. Second, this study was a cross-sectional study, so longitudinal study should be carried out in the future to investigate changes in ADL difficulty, physical functions, and depressive symptoms, to examine further to determinant of ADL difficulty in HD patients. Third, only CSD was used to evaluate depressive symptoms. More detailed evaluation, including cognitive function, will be necessary in the future. This cross-sectional study revealed that a slow walking speed and old age are significantly and independently associated with ADL difficulty. The presence of depressive symptoms was significantly and independently associated with ADL difficulty at the higher level of difficulty in ambulatory HD patients. In addition, cutoff values of 83.7, 75.5, and 75.1 meter per minute for user walking speed predicted that onset of ADL difficulty at higher, middle, and lower levels respectively. That's all. Thanks for watching. What do you think about this topic? If you have any ideas, feel free to write it on the comment. See you next videos.